Good morning, everyone, and thank you for gathering today as we tackle one of the most urgent presentations in cardiology, acute decompensated heart failure with pulmonary edema. Imagine a patient suddenly gasping for air, frothy pink sputum at the lips, sinking into a chair because lying flat feels impossible. In that critical moment, every word you say and every action you take can mean the difference between life and death. We'll start by understanding the background. ADHF is not just fluid overload, it's a delicate balance gone awry, triggered by dietary slip-ups, missed medications, heart rhythm chaos, or even a torn valve. Our goal is simple: recognize it, diagnose it, treat it, and send patients home stronger than before. Turning to slide 3, clinical recognition. Any patient with known cardiac history who presents with sudden dyspnea, whether wheezing like cardiac asthma, a persistent cough, or swelling creeping up the legs, merits our full attention. Check the vital signs. We often see hypertension, a racing pulse, and oxygen saturation dropping below 90%. Yet in advanced cases, the blood pressure may betray us, plummeting when the heart can no longer keep pace. Now, slide 4, our physical exam. Place your stethoscope gently on the chest and listen for crackles crackling through lung fields like leaves in autumn. Look for jugular, venous distension painting the neck, inspect peripheral edema, and feel for pulsus alternans, an alternating pulse amplitude whispering severe LV dysfunction. Detecting a displaced apical impulse or a new murmur can signal acute mitral regurgitation and flash pulmonary edema. On slide 5, the ECG becomes a vital roadmap. A 12-lead trace can unmask atrial fibrillation with rapid ventricular response or ST changes, pointing to an acute myocardial infarction, each finding demanding simultaneous management. Slide 6 brings our chest X-ray. Watch for cardiomegaly, interstitial edema with curly B lines, that classic batwing pattern of alveolar flooding, and pleural effusion blunting costophrenic angles. Remember though, a normal film does not rule out early HF. Next, slide 7, our Labrador Symphony. BNP soaring above 500 pg MRL anchors our diagnosis. Troponin rules in or out a silent infarct. Renal function and electrolytes guide diuretic dosing. And an arterial blood gas reveals whether the patient is in respiratory alkalosis or sliding toward acidosis. Slide 8 hands you the ultrasound probe, your bedside oracle. Seek B lines, rippling like comet tails through lung fields. Gauge ejection fraction and appraise IVC fullness to estimate filling pressures. This rapid exam transforms uncertainty into confidence. But we never forget slide 9. Other culprits lurk: ARDS, pneumonia, COPD exacerbations. History, BNP, B lines, and response to diuresis help us confirm cardiogenic pulmonary edema. With diagnosis confirmed, we move to slide 10, position and oxygenation. Elevate the head to high Fowlers, let gravity ease venous return, and deliver supplemental oxygen, keeping SpO2 above 90%. If distress persists, non-invasive positive pressure ventilation, BiPAP, can swiftly lift the patient from the depths of respiratory failure. Should they lose airway protection, we intubate with calm precision. Slide 11 calls for rapid preload reduction. Administer IV furosemide, 40 mg if naive, or at least 2.5 times the home oral dose if chronic. Monitor urine output closely. If relief lags, start a furosemide infusion at 5 to 10 mg/hour all while safeguarding renal function and electrolytes. On slide 12, we unleash vasodilators. For hypertensive pulmonary edema, sublingual nitroglycerin 0.4 mg x3 preludes an IV infusion beginning at 50 UG min, titrating up to 200 UG min to reduce preload and afterload. In cases of extreme pressure, sodium nitroprusside 0.3 OG/kg min, carefully titrated, offers potent afterload reduction. When shock looms, slide 13 guides us to support perfusion. Norepinephrine steadies mean arterial pressure around 65 mmHg. Add dobutamine 2 to 10 min or milrinone if blood pressure allows, or epinephrine in the fiercest storms. Slide 14 reminds us of morphine's place, 4 mg IV for anxiety and venodilation, judiciously used with vigilant respiratory monitoring. Slide 15 never lets us rest. Continuous SpO2 and cardiac monitoring, a Foley catheter tracking each drop of relief, frequent blood pressure assessments, and arterial blood gases guiding each breath. If conventional therapy falters, we do not hesitate to involve ICU colleagues and advance to ultrafiltration or mechanical support, whether IABP, impeller, or even ECMO. Slide 16 drives us to root causes. Manage precipitating MI with PCI, control atrial fibrillation with rate or rhythm strategies, tame hypertension with IV and chronic antihypertensives, and if valve rupture or VSDD is suspected, summon cardiothoracic surgery immediately. Finally, slide 17, disposition and follow-up. Admit the patient to ICU or a step-down unit for 24 to 48 hours, guided by Ottawa or similar risk scores. Transition to oral diuretics once stable. Optimize ACE inhibitors or ARNs, beta blockers, and mineralocorticoid receptor antagonists. Empower patients with education on daily weights, low-sodium diets, and strict medication adherence, and schedule cardiology follow-up within 1 week. For those with persistent failure, begin discussions on advanced therapies, devices, transplantation, and cement our commitment to their ongoing care. This narrative is our pledge to diagnose swiftly, treat decisively, and care compassionately. Thank you for walking this path with me. Now, let's turn knowledge into healing and breath into life.